Okay, now we're going to look at the last thing we're covering in this chapter is urolithiasis. Now, basically, what this is when calculi forms inside the urinary tract. The most common cause of urolithiasis, no matter where it is dehydration. When it forms inside the kidneys, it's nephrurolithiasis. When it forms, if it forms inside of a ureter, it can cause hydronephrosis. If the renal calculi is not taken care of in a timely fashion, because what happens is that stone blocks that urine from coming out of the kidney, and so the urine continues to back up, causing that hydronephrosis. Okay, and we'll talk about that later. That's actually next week. Urine that is high in acidity or alkalinity, or high levels of calcium, can also contribute to stone formation. Now, urolithiasis is when the stone is formed in the ureter, and just like the hydronephrosis, hydroureters is where you have that buildup of urine on the backside of where that stone is blocking the urine from leaving the body. A lot of the times, these patients are in a lot of pain. They have nausea and vomiting, a lot of diaphoresis. They also will have hematuria, and a lot of pain, and especially with that obstruction. I hope that makes a little bit of sense. One of the things we really have to look out for when you have that hydronephrosis is that it can affect the glomerular filtration rate and the kidney perfusion. When the stone occludes the ureter and blocks the flow of urine, the ureter dilates, and this can also cause issues with that urine coming out as well. Pain associated with the ureteral spasm can be very excruciating, and a lot of times these patients will have a lot of hematuria. But the big thing is that with the blockage persists, you can end up with hydronephrosis, which is the enlargement of the kidney, because of that blocked urinary outflow as well. So who is at risk for kidney stones? So who is at risk for developing kidney stones? There are some things that are modifiable and some that are non-modifiable risk factors. When you're looking at your patient, a lot of times patients who are Caucasian have a higher risk of kidney stones. Also, the patients who are obese or have a history of gout or diabetes also have a higher risk for development of kidney stones. Now, remember, anyone who has a history of kidney stones is at a risk of developing them again. Diet is not considered a risk factor for stone formation. However, high calcium levels can be. Now, interestingly enough, a lot of times when patients do have a history of kidney stones, the provider will place them on a diet that is high in fruits and vegetables, and they will lower their protein intake, and of course increase their fluid intake to help to prevent future renal calculi. It's also important to realize that men are more likely to get kidney stones than females. Kidney stones are also more common in the southern United States, Japan, and in Western Europe. Kidney stone disease is more common again in men than in women, and that's important to keep us in mind. And again, there's usually a familiar history of it as well. Patients with kidney stones usually present in severe pain. This major symptom is called renal colic, and it is a severe flank pain, suggests that where the stone is, whether it's in the kidney or upper urethra, they're usually pretty well able to spot on where the pain is where the stone is. Flank pain extends into the abdomen, or in males into the scrotum or testes. They will complain that the pain is more intense when they can feel the stone moving. they will have little urinary output, and what urinary output they do have will a lot of times have hematuria. A lot of times these patients may have a distended bladder as well. You're going to want to try to get a urinalysis on this patient. Again, hematuria during a renal colic is very common. It can also, the urine sometimes will appear not necessarily like bright blood red. It's more of a rust color or an orange red. It's not really like a bright like hemorrhage red. It's more of a rusty color of red. If these patients do not have any urine output or very little, it can be an obstruction and can be an emergency. They are going to still want to complete a KUB, which is a standard x-ray of the abdomen. A lot of times they will do an ultrasound to see if they can see the renal calculi as well. But normally they will do a KUB, which is just a chest, an x-ray of the abdomen. So a KUB would be an x-ray of the abdomen. And that is what they will normally do to be able to find the where the stone is located. So moving on to nursing interventions. What is the nurse's responsibility during taking care of patients who have renal calculi? Well, the nursing interventions are to control their pain, to make sure that we're preventing infection, and that we are making sure that they are not having a complete obstruction of their urinary output. With that being said, we a lot of times will have to teach the patients how to strain their urine. Sometimes they will give them antibiotics. Most patients will pass a kidney stone on their own and not require surgical intervention or any other intervention. They normally will pass them spontaneously on their own, but sometimes they won't pass them on their own and further intervention will be needed. But the majority of patients do pass the kidney stones on their own. Pharmacological interventions used to take care of the patient with kidney stones. A lot of times these patients need fairly regular doses of opioid analgesics because the pain can be quite severe. Sometimes they will get relief with nonsteroidals, but it's usually they're using more of the Karalectate or the Toradol to help with that pain as well. Most of the time, these patients are given their pain medicine on a more routine basis than in a PRN basis. They're also a lot of times given antispasmodics to help with the spasms in the kidney area and in the urethra and the ureters to help with that pain control as well. Other management techniques is to make sure that the patient is not being overhydrated or underhydrated in the acute phase, making sure that the stone passes as with the least amount of pain possible. Again, we've already talked about needing to make sure we're straining that urine. Sometimes patients will be placed on antibiotics to circumvent any type of infection from having that stagnant urine. It depends on the patient's comorbidities. A lot of times, patients are not treated. Antibiotics, the book says that they are generally treated with antibiotics, but sometimes I see that they haven't been. Does that make sense? Anyway, two drugs that can be used to help to encourage that kidney stone to come on down is a thiazide diuretic. And sometimes patients are placed on allopurinol, which is a medication used for gout, getting rid of that uric acid. Okay, so that's what we need to know about drug therapy and the kidney stone. So what do we do if these patients are not able to get past the kidney stone on their own? Treatment can be with lithotripsy, which is people will talk about they had their kidney stones blasted. It can be with a laser or dry shock waves to break down into smaller fragments so that they're easier to pass. Sometimes patients are urinary stents will be placed. A lot of times you'll see this, especially with patients who have had repeated kidney stones and have had issues with having repeated kidney stones. They talk briefly in the book about open surgical procedures for kidney stones. I've never really seen that very. I don't think I've ever seen that at all. I do know that it does happen with patients, especially if they have, um, you know, they will do a surgical removal if they're having hydronephrosis or completely anuric. They will go ahead and do a surgical procedure. But most of these patients are passing enough urine that they don't have to have a surgical procedure done. So what we need to do as nurses to help these patients care for themselves at home is to make sure that we're preventing obstructions. We want to make sure that if the patient is placed on medication, that they take them completely, that they look at treatment for high calcium levels. They may be placed on a thiazide diuretic to help to keep their urine flowing and to decrease those high calcium levels. They may if the patient is found to be hyperuremic or with gout, they'll stay on the allopurinol to assist with helping to keep that the renal calculi down as well. There's some great key points for self-management in chart 6611. It talks about things to make sure that the patients are aware of when they're going home, like making sure they're completing all of their antibiotics, when they can resume their daily activities, making sure that they're drinking plenty of fluids. They may even have to monitor their urine pH. Sometimes patients will have bruising after the lithotripsy where they have bruising, and the bruise can be quite significant, and they need to make sure that they're making sure that that bruise stays nice and soft and doesn't become hard like a hematoma. Their urine may be bloody for several days after surgery or even after lithotripsy. They still may have some pain in the region of the kidney from where it started to begin. You need to make sure that they are aware of the signs and symptoms of an infection and to make sure that they're following up with all of their appointments. When patients are still trying to get that kidney stone to pass, there are some things that we as nurses can encourage them to do. Once we get their pain under control, sometimes if they're walking around, that will help to get that stone to pass more quickly. That will help as well. So that's about it as far as kidney stones go. We'll start back with our next lecture, and at that point we will be talking about, let's flip the page and then we won't have to look at it. Let's see. We will be in chapter 72, care of the male patient with prostate problems. And we will pick up on that. I'm probably going to record that in the afternoon tomorrow because, as you can hear, my voice is starting to crack. So I'm going to call it a night. I hope that you guys are finding that this way of doing your tapes is more interesting. Please give me your feedback. Thank you very much.